Um, Thank you, everyone. The acoustics are just really bad in this room, so if my voice drops, perhaps someone could wave at the back. I also have to say, it's sort of being on a stage with all these bright lights in my eyes, it's difficult to see as well, but we'll see how we go. So the piece that I want to pick up is around integrated commissioning, and I guess my sort of theme for this afternoon is one that integrating the commissioning of health and social care is the only model for the future. So let's not talk about anything else. My belief is this is the only model. So let me try and get my technology working. Okay, so we all know the environmental context we're working in. A number of people will have said similar things earlier today around the growing population ageing, technology, less money, but a real need that we have to improve both across health and social care, outcomes, choice, personalisation, quality, safety, and we could go on and on. It is a massive list. And for those of you who remember the hallowed days of what PCTs had, Primary Care Trust, which was world-class commissioning, at that time there was a phrase around adding life to years and years to life. So this wasn't about just making sure that people lived longer, but there was a quality of life. And I think that's as true today as it probably was a few years ago under world-class commissioning. So I want to give you a flavour of some of what we've been doing in Kingston. I'd like to be able to describe that we've worked through it all. We've got a new model. It's fully integrated, both in terms of provision and commissioning. No, it isn't. But I want to describe some of what we are doing. And the first thing that we've done is through our Health and Wellbeing Board. In April, we agreed that our vision here is that if we integrate our commissioning, we'll deliver better outcomes and better value for money than we can achieve commissioning separately. And just to say that Kingston is a London borough, it's a unitary council, but it's a small borough, so our population under 200,000. And therefore, to run two systems, and that's part of my argument, actually is very costly and it doesn't deliver the sort of outcomes we want. Now, if you're working in a big county council, there's a different context, but I'm going to give you a flavour of what we're doing, and hopefully you'll see some resonance to what you're doing. So my other challenge, and I'm quite deliberate about using the word broken, because I think what we've got, if you look at what we're doing and way both provision works, we know whether it's at a system-wide level or whether it's at the individual level of the individual client, the system just is not working. So our existing arrangements are just far too slow to deliver the scale of transformation, both in health and adult social care, quickly enough. I think we've got two largely unconnected governance systems within the council and within what's been created for clinical commissioning groups, which is a very, very prescribed way of working. There is a lack of clarity, so where we've put in joint working arrangements, whether they all neatly tie together, they don't. My sense is since April, the system is becoming far more complicated because whilst I think at a local level, lots of people think that the clinical commissioning group is responsible for all the NHS, those of us in CCG know that that is not the position because you've got NHS England commissioning primary care, you've got Public Health now with the council, you've got Public Health England with an interest around health visiting. So we've created already a fragmented system. And our funding systems, and I'll come back to this, are becoming far more complicated than we had before. Some of the work we've been doing is clearly what it's doing. It is just blurring the boundaries between health and social care. So within Kingston, there is a social enterprise which the PCT set up a few years ago, running our community health service, community nursing, community beds, and those sort of services. And we've just transferred in some social care into that. But the way we've had to do that is to bolt this onto the standard NHS contract, and then we need to find a way of shifting the money from the council into the CCG. But at a provider level, what we want is one system. And I think certainly I only heard a couple of presentations earlier, but at an individual patient level, frankly, it probably doesn't matter whether it's health or social care. So at a provider level, we're blurring that, yet we've still got two very separate systems we're working in. We know we've got stretch management capacity across the system, and I think what we're observing is, unless we sort out some of the issues I'll come on to, there is a real danger of cost shifting. So potentially, greater investment in social care, but savings within NHS, because what we're trying to do is to reduce admissions. Well, the NHS will get the saving, not social care. So why integrated commissioning? So what we're seeking to have are fewer admissions into acute hospitals. I think also, and it's important for me, but it's also fewer permanent placements into long-term residential and nursing care, because that is also incredibly costly for the system. We want more care for people at home for longer, improved outcomes, but also between us, a greater ability to manage some of the pressures going forward. The council's budget, certainly in Kingston, we've had a significant reduction in the grant, despite the council also putting up council tax. We know from a CCG side the budget is under significant pressure, and if we carry on that way, the system will get more and more disjointed. But what we've also got to deliver is we've got to get some savings both for the CCG and for the council. And I'll be the first to say, of course, this is about providing better care and better outcomes. But unless we get the money out, actually, the system just will not work. I think, there's somewhat of trying to put a reality check around some of this. So a couple of my challenges there are, and in a way, back to, where is the evidence on some of this? So, and I'm a believer in this stuff, but we all know there's probably lots of people, we will all know them in our own systems, who actually will say, well, how do you know that integrated care is better for patients? How do you know it will deliver savings? So where is the evidence? And I think one of my challenges is to some of the national bodies, and the previous speaker from the Department of Health was talking about what the national bodies are doing. Are they really collecting the evidence that we can all use, rather than having to repeatedly collect all of this? And the other challenge is, and I work across both systems now, is our systems are just completely different. And we're trying to do what we can at a local level, but some of that is very much hampered by the systems that sit above us. I think if you talk about the money, my sense of this is anything to do with money, whether it's around funding, the financial flows, the currencies, how we manage financial risk, who gets the savings, we've just got to sort all of this out. And certainly what we're thinking of doing in Kingston is we will go for one of these 10 pioneer bids. It will be around this one, because we want to make sure, because I'm a great believer that unless we sort some of these issues out, you will not get the system to work. These things get in the way. Local government works in a political system, less so within the CCGs. But I think critically, for me, this is around the sharing of power between GPs and between the councillors, and we've got to find a way of doing that. And my challenge back to people, and I challenge my own GPs on that within Kingston, which is just turning up once every 2 months at the Health and Wellbeing Board is very different from this. This is about really working together, and GPs really working with the councillors at a very local level. So what are we doing? So you may be doing something similar. I'll be interested to hear, is trying to integrate our adult social care service with NHS Community, run by the social enterprise in Kingston. The Health and Wellbeing Board, we've at least agreed a direction that where we're going to integrate commissioning. We are working through the detail, and particularly around what are the governance structures. So if we're going to bring this together, what sort of governance structure do we wrap around this? And then flowing from that, how do we make the system work? And if you ask me, and what's the answer to that question? I don't know. We're trying to work it through. And some of where we're looking at are places like Lincolnshire, which has actually tried to do some of this, but also, in a sense, learning from what others have done elsewhere, so whether it's Solihull or Torbay, in terms of let's not repeat the mistakes of the past, what can we learn there? We've just joined up our children's services, so the services provided by Richmond and Kingston councils, we've joined that up, and there's a single director of children's services across the two councils. And then we've just reopened a new health centre and co-located on that side a primary school, which I think, again, is quite new and innovative, certainly in our borough. So, again, we're doing some of those things. I think our big challenge is to invest. How do we get enough money out of the system to invest in prevention and care at home? Because that's our strategy. Our strapline project is what's called Kingston at Home. If you Google it, right, it should come up, hopefully. Our whole process here is around how do we support people for as long as we can safely in their own home. So that's one of the key themes. The next one here is around something that's called Care Connect. So the NHS, and Tim Kelsey, who is here and spoke at one of the sessions earlier, is rolling out this new system, Care Connect. It's to allow patients to have a far better voice into the system, and we're about to roll that out. It's a web-based system. I describe it as TripAdvisor, which everyone tells me, no, that is completely the wrong way to describe it. But it's a way of allowing patients and users to put in comments, feedback around the system, and for that to be picked up by us as commissioners, as well as people getting an immediate response. So we're very, very keen of getting that patient voicing here. And the other thing that we've got is, as we all will probably have, is quite a lot of joint working arrangements, so shared posts, joint commissioning managers. But the other thing we've been doing is, as we're starting to bring health and social care together, the only practical way of doing this is you start to have to create honorary posts or secondments. And really, the more of that you do, the more messy it gets. So, for example, my head of adult safeguarding, who is employed by the council, is also providing that function for the clinical commissioning group. But his contract is with the council, so we have to put in place an agreement. And my challenge is, you can't keep doing that for every single person. You know, you've got to create some sort of framework around all of this, and we're trying to sort out some of this. So finally, and very happy to take questions and comment, I would say I've tried to give you a perspective on what we are doing. I'm as interested in much in terms of, so what are you doing? And if people have actually found a way through this and want to email me, then one of the things I want to do is to try to create some sort of network for people who are really interested in the commissioning piece. Lots of others are doing the provider piece, but so if you're interested in this, please drop me a line at Kingston, and then we can maybe start some sort of network between those of us who are interested in moving this forward. Okay, thank you very much.
Thank you, David. Right, comments or questions to David around joint commissioning? Yeah, there's a... Sorry, I can see a fair-haired person in the back row. Can't see male or female.
Thank you. Beverly Home from East Sussex County Council. I also manage joint commissioners with the CCGs. I'm interested in your idea about integrating commissioning and how far that's taking you down the road of really pooling budgets. Obviously, with the huge amount of risks that's involved in acute, and the real challenges of disinvesting from acute in order to beef up our community provision, are you engaged in a kind of a risk-sharing arrangement around your total budget, or were you actually talking about aligning commissioning and aligning budgets rather than genuinely pooling them?
Okay, so I mean my my view, my personal view on this is what I'm seeking to do is to integrate the total budget. To integrate, so the CCG budget is 200 million, my social care budget, my net budget is 55 million, and what I'm talking about is bringing the two of those budgets together into a single budget, and then effectively commissioning total pathway of care through that single budget. Now, and hence why I made this point earlier, that therefore what gets in the way is what's our contracting mechanism, what currencies are we going to use, and then how do we manage risk across. But that is where I personally believe that I want to get to. We haven't found, let me be clear, if we'd found a way, we probably would have done it. We haven't. And one of the things I'm certainly very keen of testing out through the Pioneers programme is how far can we really push this? And it may be that there are some of the restrictions, particularly I think that are laid on CCGs, that we're going to have to challenge and get some of those changed.
Okay, thank you. Other questions or comments? Yes, there's a gentleman at the front.
Hello, I'm James Lampert. I'm a commissioning manager with Kent County Council. And actually, it's around about 8 or 9 years ago, I had the pleasure of working for Kingston for around about 4 or 5 years. So,
Good.
It's good to hear how much further you've come along since then. One of the challenges in having actually worked in a unitary and understand in some ways how much easier it can be. I think there are some other challenges which are faced by two-tier authorities. So in County Council we work with 7 different clinical commissioning groups. And I think our ambitions similarly will be around how you can go about creating more budgets. That's something in terms of a network that we're really keen to link up with this particular line. My question really was around how you're working with your health and wellbeing board and maybe some of the public health interfaces as well in relation to joint commissioning.
So with the Health and Wellbeing Board, if you go back to the, it must be nearly, 18 months when Andrew Lansley published his original, whatever it was, white or green paper on all of the changes. It was at that stage, we just set up the Health and Wellbeing Board as an interim, well before all the legislation came through. And that, I think, was very helpful to get the GPs and the councillors, some of the councillors around the same table, getting them talking, because previously, actually, they never did. I think where we are struggling at the moment is to really think through, well, what is the role of the Health and Wellbeing Board? And I think a number of us would want to position it that the role is around driving integration. But what I see is happening is a lot of stuff is being thrown at us. And a lot of it is coming down from the centre, which is sort of, it does seem to be now, in whatever letter we get, particularly from the NHS, which will say, here's an issue for the Health and Wellbeing Board. And there's quite a raft of that coming through. And my worry is that if we're not careful, we're going to be sucked into a lot of the operational detail, where the real advantage is going to be driving the strategy. So I'm concerned where we're at. And I think it's a perennial issue we go through. I think every time we try to set an agenda for the meeting coming up is, well, what items do we put on the agenda?
I absolutely agree with you. I think that's a real challenge for health and wellbeing boards. They'll get sucked to do something they were not intended to do to help the Department of Health performance manage the system it can't performance manage.
Yeah.
I absolutely agree. Any other questions? Comments? People work in joint commissioning? Apart from the gentleman there? No? Yes, lady here.
So there's a lady there.
Have you got the mic for the lady here, please? Thank you.
Yeah. So what's this?
I'm not in commissioning. I would be looking at provider side. At the moment, I'm from Alliance Boots, but we have a home care division, actually, which is the main reason I'm here today. And at the moment, we do clinical home care, but we are looking at other areas as well. So would there be value in providers actually working together to facilitate your joint management of social and healthcare provision?
I think the simple answer is absolutely yes. I think where we struggle is how do we actually, what do we need to do? And I think both with, I mean, if I look at, just to describe Kingston, which is in some respects a relatively simple system, where there is an acute, and I'll talk about the health side first, one acute provider, one mental health provider, a social enterprise that's just providing community health services. But the struggle we have in order to try to actually even practically get people to meet, let alone doing some of the redesign of the pathways, it is just difficult enough to get the 3 NHS providers together, let alone the proliferation of all of our social care and private providers. So I guess in my wildest dreams, I do think of a world where almost you could have a lead provider model, where as commissioners you could have a single commissioner with a lead provider and the provider running that network. But then I wake up.
Well, theoretically, I mean, if we're talking about, say, early supported discharge from hospitals, and it's Health+Care at Home have done a basic model in
Yeah.
Southampton, but if we were looking at that sort of thing, that's exactly what would be needed, is that you might be joining up what Boots do in 2,500 pharmacies with what we do in homes, but you would also have to properly integrate with the hospital and with anybody else around.
Yeah.
So
Yeah.
actually understanding how that would be most effective for the commissioning groups. And given that one of our offices is in Chessington, perhaps we're very close to you.
No, absolutely, very happy. Yeah. No, very happy to have the conversation.
It's about understanding it a lot of the
Yeah.
time first, isn't
Yeah.
it, before we can move on.
Yeah.
But in a way, isn't part of the issue is the curse of procurement, because that always limits the opportunity for creativity on the side provider. Maybe joint commissioning in collaboration with the innovative providers might just give us a clue on the way forward. But we'll still have the curse of procurement. You know what I mean?
Yes, but we are used to being at the front, so
Yeah.
I'm sure others are as well.
Yeah.
But actually, somewhere it's got, I think conversations I've had today have been about starting with pioneers in exactly the same way you, and it may not be exactly what you would choose as your first priority, but it's about what can you get on the ground that's effective,
Yeah.
working with pioneers who
Absolutely.
stick their necks out.
Yeah. Yeah.
Okay. Any other comments, contributions people wish to make? We are allowed to finish early. Okay. Well, I just want to thank David Smith
Thank you
for
very much.
sharing with his thoughts from a real live situation in Kingston, and wish you well in your endeavours to become a pioneer, David.
Thank you very much.
Thank you very much.
Cheers.
Thank you.